Kia ora koutou, i ngā mana, i ngā reo, i ngā karangaranga maha. Tēnā koutou, e te whare etu nei, tēnā koutou, e te toi mata hauora, tēnā koutou, tēnā te mihi, kia koutou, tēnā koutou, tēnā tātou katoa. Good morning, everybody, and thank you, Murray, for that introduction and for raising those expectations. I want to begin by saying, look, it's a genuine privilege actually to be in the role of Minister of Health, and I know it is a very challenging time, it's a very challenging sector. I haven't had a former Minister of Health yet in their messages to me say just congratulations. It's usually congratulations and commiserations. That might just underscore the fact that there are some very serious challenges actually that as a country we need to meet. So, look, thank you for the welcome and for the opportunity to be here. I want to make some acknowledgements. In addition to you, Murray, I want to acknowledge your Association National Executive, your Executive Director, Sarah Dalton, who I'm coming to know. I think we've met a few times now, Sarah, and I look forward to continuing and establishing the relationship with Sarah, with your organisation, and so on as well. I want to acknowledge the Association's members. This has been, look, putting everything else aside, this year in particular has been a really tough year. It's been a tough year for every New Zealander, but it's been a tough year for the health sector as well. And the demands that the political leadership of the country have put on the sector to kind of suddenly pivot and turn around and be the critical frontline response to the pandemic has been a big ask, but our health sector, our health professionals have responded in an incredible way and in a way in which I know, every New Zealander will be most thankful for. It's not only required a shift in attention, it's created disruption, and even for those who might not have been on the front line of COVID-19, there is now the work of sort of the massive catch-up of work that wasn't done during those critical periods in March and April and subsequent months this year. So I do want to acknowledge you and your members and the incredible contribution that has been made. As Murray has acknowledged, as some of you know, I have a union background, so I know the very important role that an organisation like yours plays. For medical professionals, for you and others in the sector, your role as advocates for patients, for those in the system, at an individual level is absolutely critical. But part of the advocacy for medical professionals is not just for individual patients, it's for the system as a whole. And the best voice for making sure we have the best system is a collective voice that organisations like the ASMS brings. And so I thank you, perhaps I thank you in advance for the advocacy that I know you will bring as we go through, I think, a period of change and rearrangement. So, in summary, let me just say thank you for what you and your members do individually and collectively. As I said, we are going to go through a period of change in the next few years, and I look forward to working with your organisation and others in the health sector as we face those challenges and as we make those changes. Conferences like this are an opportunity to exchange knowledge and experience and to support each other and to share in the camaraderie of the profession. So good on you for doing that. I understand there's about 160 of you here. A rough estimate, that looks about right, comparing it to Labour Party conferences I've spoken to. And I know, if only from the news broadcast in the last 24 hours, that you've had some very, very important issues to discuss, and I hope that we can engage meaningfully on those, not just today, but as the months wear on. I'm aware that you and, of course, your colleagues are our leading clinicians, and so, as I said before, I offer my thanks to what you have done. I've acknowledged the sort of year this has been, with the challenges of COVID-19, and again repeat my thanks for the effort that has been made, and I know that many New Zealanders will be thankful for it. I'm now apparently into day 25 of being Health Minister since Jacinda Ardern appointed me to that role. And one thing is very clear, I have a lot to come up to speed on and a lot to learn. I've spent the last few weeks doing a lot of reading, a lot of listening, There's still a lot more listening to go. I cannot believe the number of advocacy groups and interest groups that there are in the sector. That's by no stretch a criticism. It's an important thing. But it demonstrates to me the complexity of the system, the sophistication of it, and, if anything, to kind of explain the challenges that we have, because there is a lot to get right. Look, I don't think anybody would ever argue there's any such thing as a perfect health system, but we can aspire to have a bloody good one if we do the right things, and that's what I'd like to achieve. I can guarantee and assure you that my determination is to seek certainly a more sustainable, but actually a more equitable health and disability system here in Aotearoa. I understand that the ASMS supports the government's decision to separate out the leadership of our cross-agency COVID-19 response from the health portfolio, and there's no question my colleague Chris Hipkins is doing a terrific job in leading the COVID-19 response, but that occupies a large chunk of his working day and week. And actually, we kind of need to focus on the business as usual stuff as well, because that has been somewhat neglected in the last few months. So obviously I support the Prime Minister and her judgments, but it was the right thing to do in my view to separate that out and now give me an opportunity to put some focus on some of the other issues. We want to make sure that the reforms that have been somewhat anticipated in the Simpson report continue with the right focus and energy and aren't sort of second fiddle to the range of other issues that could happen in dealing with the COVID-19 response. Chris Hipkins and I will be working closely together over the coming period because so much of our pandemic response involves the whole system anyway. So we have to work closely together, and we do, and we are. But my main focus will be leading the reforms of the system, which I'm going to talk more about very shortly. I'm responsible for the overall function and operation of our health and disability system, community health, health workforce, aged care and mental health services. Of course, I'm very privileged to have the support of 3 associate ministers, Pēni Henare, who's responsible for a number of things, but principally Māori health, and he and I will be working closely together, because I think a measure of the reforms is the extent to which we close the access and services gap for Māori. Opito Williams-Seal, who, amongst other things, will take principal responsibility for Pacifica Health, and somebody who will possibly be familiar to you, Dr. Aisha Verrill, who I understand is a former, if not a current member of your organisation. There you are. And she's doing a terrific job already, also working with Chris Hipkins, working with me as well. And look, we are, as a government and as a party, just so privileged to have somebody of Dr. Verrill's capability to come in straight, not just into Parliament, but into Cabinet, playing the role that she's playing and providing fantastic leadership. She will bring, and I see it in all the meetings I've been through with her there already, the clinical expertise that she has to the very heart of government decision making. And she will bring a particular focus on public health. This will be invaluable, not only for our pandemic response, but actually for the general stuff that we do anyway. Very good also that Pēni Henare will continue his role, his associate role on health, and his focus on Māori health. And as I said, Opito Williams-Seal in the Pacific area as well. This, or the hard work and leadership and advocacy and representation that each of those associate ministers will bring will be vital as we develop greater fairness in our health system. As I said before, achieving greater equity is a major focus of the government's response to the Health and Disability System Review's final report, Pūrongo Whakamutanga, or more commonly known as the Simpson Report, because of who chaired it, Heather Simpson. The government has the mandate to progress these reforms, and as I've also said, leading these changes is really my top priority. I know my predecessor, the Honourable David Clark, stood on this stage 2 years ago and urged you to contribute to the review, and I know you did, and you did with aplomb. and I want to thank you for the contribution of your wisdom and expertise to that. I'm sure many of you will have read the report. I'm reading it in very fine detail at the moment, and if you haven't read it, then I encourage you to do so. As I say, I picked that up. I had to pretty much as soon as I was appointed, and I'm pretty sure it's a document that's going to be by my side for time to come. That review found that we have a very good health and disability system, but it also confirmed that our health and disability services are under considerable stress and our system is fragmented and complex. Our COVID-19 response has exposed gaps in our system and underscored the fact that some New Zealanders aren't receiving the care that they need. I might also add that COVID-19 response demonstrated what is possible with a necessary spirit of collaboration to respond to a major public health crisis. Now, for example, I've recently learned of the impact that the lockdown and more rigorous PPE requirements have had on waiting lists for hospital-level dental care for children. I understand we also have a problem in making sure children receive their scheduled oral health checkup on time, and it's Māori and Pacific children who are bearing the brunt of the delays in this area. Given the importance of good oral health among our children as a foundation for good oral health over the entirety of their lives, this is a matter that I will be following very closely. I also acknowledge the frustrations raised by your members recently about growing demand in our hospital emergency departments. I've heard your concerns about how this may be linked to the difficulties some of our most vulnerable New Zealanders experience in accessing primary care. People don't go to the doctor, leave things, leave it, before they know it, they're turning up to the ED in a situation way worse than had they been able to get access to primary care much earlier. Health officials tell me that ED presentations have increased by 10% over the last 5 years, and this has been further exacerbated by the COVID-19 pandemic. I know the Ministry of Health is working with DHBs to improve acute patient flow and other processes, which we all hope will help in taking pressure off EDs. DHBs are also working with primary care providers on initiatives which should promote better access to primary care. Improved access to primary care remains a priority for the government. We acted quickly on this in our first term by extending cheaper doctors' visits to community services cardholders. The Simpson report has set a path towards a more sustainable and equitable health and disability system. That includes greater emphasis on primary care, one in which situations like those I've just mentioned are less likely to develop. We know the system is failing Māori, and as a result, significant health and wellbeing inequities have been created. As Murray acknowledged, as Minister for Treaty of Waitangi negotiations for the last 3 years, and a role that I'm very happy to have retained, I'm well aware that decades of health policy have failed to ensure access to health care in isolated and marginal communities, which has seen many Māori suffering worse health outcomes. It's vital that we turn this inequity around, and I'm determined that we will. The Waitangi Tribunal released its report, Hauora, report on stage 1 of the Health Services and Outcomes Kaupapa Inquiry, the Hauora report, in July last year. That report and Pūrongo Whakamutanga highlight that we need to do more to move to a Treaty of Waitangi compliant and equity-focused system. The government is already moving in this direction. Over the past 3 years, we've begun and progressed a series of initiatives to support improved outcomes for Māori and Pacific peoples. For example, last year's wellbeing budget included additional investment in our Māori workforce development package to incentivise and support hundreds more Māori students into health professions. We invested in the Pacific Provider Workforce Development Fund to help develop a strong and sustainable Pacific health workforce and leadership that can contribute to reducing Pacific health inequities. Earlier this year, Minister Henare launched Whakamaua Māori Health Action Plan 2020 to 2025, which sets the pathway towards achieving pai ora healthy futures for all Māori. This is the first Māori Health Action Plan in almost 10 years. It's well aligned with the Simpson report, crucially because the Simpson report recommends we establish an independent Māori health authority. This authority, once established, should have the licence to be a game changer for Māori health services and outcomes. It needs to. Another major recommendation in the Simpson report is to combine some DHBs, resulting in 8 to 12, fewer DHBs, roughly 8 to 12. But the objective of that recommendation is to have strong organisations responsible for delivering services in the areas. One of the things that I'm becoming acutely aware of as I sort of get into understanding the way the sector operates, and particularly the way the ministry operates, and the frontline health providers, including DHBs, is just the not quite disconnected, but certainly fragmented nature of decision-making across the system. And we have to reorient that so that we see all the participants in the system as working for a nationwide system, a system as a whole. And a country our size, to do otherwise, runs a very real risk, which may well be happening now, of duplicated effort, of wasted effort, and therefore of wasted resources. We still have more work to do to determine the overall future structure of the health and disability system, but the most important thing is to ensure services deliver what New Zealanders need and deserve. Cabinet has already signed off on the general direction of the Simpson report. The Prime Minister, Jacinda Ardern, is leading a group of ministers to drive these changes. That group includes, obviously, myself, also Minister Henare, and, of course, a crucial person in all these things, the Minister of Finance, Grant Robertson. We've set up a transitional unit to carry out detailed policy and design work. That's led by former Director General of Health, Stephen McKernan, and administered by the Department of Prime Minister and Cabinet. So some work is well underway. There'll be some, I wouldn't describe them as interim decisions, but some early decisions by the end of this year, but the critical decisions will be made in the early part of next year. I'm anticipating a draft future system operating model will be completed shortly, and then we will make final decisions, as I said, on that early in the new year. The Simpson report suggested a 5-year timeline to implement the changes it recommends. I think that is too long to make changes to a system that is crying out for change now. In my view, we should take 18 months to 2 years to make the foundational changes that we need to make, some of those structural changes, so that the work of establishing processes and practices and culture can then begin. I acknowledge there is a lot of work to do, and I look forward to sharing progress with you in the near future, not just sharing in news of the progress, but engaging in what that progress looks like. In terms of our wider work program, improving our country's approach to mental health and addiction also remains an important government priority. We're well underway in implementing the recommendations of He Ara Oranga, the report of the government inquiry into mental health and addiction, and I want to continue to press forward with those changes. As you'll remember, last year's wellbeing budget invested $1.9 billion in mental health and addiction initiatives over 5 years. This significant and sustained investment is across a range of portfolios. It's not just health. It's also in education and corrections and justice and in housing, because we know all these other areas are also determinants of health, including in mental health and wellbeing. I intend taking a close interest in the rollout of services and additional support to ensure Cabinet's expectations are being met and this work is being kept on track. Where possible, I look for opportunities to accelerate progress. One of the key challenges we face in this area of work is common across our health services, as you've identified in your report, building the workforce pipeline, stopping the drain. And I want to turn to some of those workforce issues now. I can assure you that the theme of the report, your report and your conference, resonates strongly with me. I'm aware that the health and disability system faces various workforce and cost pressures. The Simpson report includes a suite of recommendations to ensure our workforce is planned and managed more effectively to meet these challenges, something that I understand the ASMS is calling for. I'm eager to progress solutions to these challenges. Additionally, on workforce, I'm also aware that some progress has been made to address gender pay issues, which the ASMS has raised following research that showed female specialists were paid 12.5% less than male counterparts. DHBs have acknowledged that a pay gap exists and they are working with you to understand the reasons behind it and how it can be closed. I might add, this has been an issue across the public sector as a whole, but in this day and age, there is no defence of it, there is no explanation for it, and we have to get on and deal with it. In September, a gender pay working group was established between the DHBs and ASMS. The gender pay gap is not limited to pay alone. It also requires us to remove barriers from allowing full participation in the workforce for women and to address the challenges they may face compared to their male peers. Finally, I want to thank ASMS for writing Your Health Matters paper, and I have to say it aligns well with the government's focus on wellbeing. As your paper correctly points out, we must tackle the broader socio-economic and cultural determinants of health if we are to achieve equity of health outcomes and in order to truly lift wellbeing. The government has the mandate to continue to tackle these issues. In our first wellbeing budget last year, we identified priorities where we could make the greatest long-term difference to improving New Zealanders' living standards and wellbeing. This year's wellbeing budget focused on rebuilding together. It included a $50 billion COVID-19 response and recovery fund to help support New Zealanders and the economy through the effects of COVID-19 and the global recession. As the Prime Minister said when unveiling our new cabinet at the start of this month, the government's priorities for the next 3 years are to drive our economic recovery from COVID-19 and to continue our health response to keep New Zealanders safe from the virus. This year's Vote Health funding reflects the most significant pressures on the health and disability sector, our COVID-19 pandemic response, increased demand from population growth and ageing, and increased costs due to wage and price inflation. It includes the biggest ever increase in funding for DHBs, an extra $3.9 billion over 4 years, as well as additional funding to deliver about 153,000 more surgeries and procedures, radiology scans and specialist appointments to help clear the COVID-19 backlog. We've committed record levels of investment into our health and disability system in our first 3 budgets. I acknowledge that just as the unfortunate effects of underfunding emerged over many years, in many cases it will take time for our increased level of funding to be felt in your day-to-day work. Implementing the reforms recommended in the Simpson report will help to ensure the system's financial sustainability into the future. So let me close by saying that, again, thank you to your incredible contribution towards keeping New Zealanders safe and healthy, and particularly during this pandemic. I look forward to hearing about the outcomes from this conference and to continue to work with you over the coming 3 years as we seek to make change for the betterment of everybody. Thank you once again for inviting me here today.
Thanks very much, Minister Little, for that very encouraging initial talk to ASMS. It's very encouraging that you have seen the publications and the research that we do and you're familiar with those. It's very helpful. And we look forward to maybe some frequent collaboration in some way with yourself at times the next 3 years. We've been using Slido, which is a gadget which gives questions from the audience. They're coming up to Sarah here. We have about 5 minutes. Are you happy to take 5 minutes questions?
Make it 10, 15 if you like.
Okay.
I'll see how the questions go first.
Yeah.
Okay, do you want me to read them? Or do you
Maybe if you can probably read them easier than me.
Okay, Minister, will you commit to a Royal Commission or parliamentary inquiry into systemic industrial bullying of healthcare workers by managers across all our DHBs? It's a nice easy one for you to start with.
Yeah, look, I totally hear the point about bullying in the workplace, and I know, strange as it may be for a caring profession or caring professions, that it happens and it is serious, and there has to be an effective response to it. Whether or not a Royal Commission of Inquiry is a response to it, I'm not sure. We've done a number of Royal Commissions of Inquiry, and in the last 3 years, they are, the biggest of which is the one into historic sexual abuse of those in state and faith-based care. and that's a 5-year inquiry. We have a range of laws to deal with workplace bullying and harassment. If the laws aren't up to scratch, it's we can deal with that. But in the end, it's going to be management practice, management conduct, and management behaviour, and management leadership that is going to determine, the behaviours, the tolerated behaviours in workplaces. So, while I'm happy to commit to this being an area of work that we put some focus on, I'm not sure I would sign up at this point to conducting a Royal Commission of Inquiry into it.
What are your plans to address chronic staff shortages across the health workforce? Every shift I work, thank you Tanya, there are unfilled staff roles.
And this is an area that the Simpson report spent some time on. We know in the last 3 years there's been a net increase of medical professionals to the DHBs alone, much less the front line, and thinking about new ways of delivering forms of healthcare as well. We know that for a country like New Zealand, with our 2 medical schools, with the capacity that they've got, we rely in part on them. We rely on folks coming from overseas to staff our health system. And the pandemic response kind of really cuts through a lot of that. So I acknowledge that there is much more to do. I think the Simpson report talks about the need for much better workforce planning. And I think the ASMS report talks about the need for better data so we can actually do that planning. I have indicated to Ministry of Health officials this has got to be a priority area in this day and age for a sector this important and this large in a country like ours. The idea that we don't have a plan or a strategy for workforce renewal and development just seems criminal to me. So that is a priority piece of work that I want us to get onto straight away.
Would you fund DHBs appropriately instead of asking them to, quote, live within their means?
Yeah, well, that's the $64 million question, or $64 billion question, depending on how you look at it. Look, there's always going to be a debate about what is a proper level of funding. I've raised the question in most of the early briefings I've had with the ministry, with the transition unit, with anybody else who cares to listen. In a country of 5 million and anticipating 6 million in less than 20 years and 7 million and probably within 30 years, with our kind of level of collective wealth and with the nature of our population and its profile, what is an appropriate level of health spend? Yeah. We can do the comparators with overseas, and we do that. We compare ourselves with OECD countries, and we are sort of mid-range there. But what is the right level of health spending? Ultimately, that is a political question, and that is a subject of political debate between elections and during elections. But there is a finite funding to go to any sector, but including to health. I think what's important, and one of the gaps, and I think it's identified in the Simpson report, is the way we fund health and the certainty that it gives those responsible for making financial decisions as well as clinical decisions about certainty for the future. And I think we can do a lot better in that regard. But how we negotiate and mediate what the appropriate level of resourcing is, that's a subject of ongoing political debate. And not just how much we do for the sector as a whole, it's where it goes. Do we spend more on pharmaceuticals? Do we spend more, put more into primary care and access to primary care? What do we put into the secondary and tertiary care levels? Those are judgments that are being made all the time. All I can do is say, keep up your voice, keep contributing to the debate. Your voice is essential, but it's not the only voice and it's not the only consideration that gets taken into account.
Time for one more?
Yeah, sure.
Okay. ACC has almost $50 billion in investment reserves. At conference yesterday, it was suggested that ACC should allocate more funding each year to provide better emergency and trauma care in our hospitals. Do you agree?
There's two ways of answering this. One is to say that I'm not the Minister for ACC, so it's not my responsibility. The other is to completely throw caution to the wind and say, in spite of the fact that I'm not Minister for ACC, about which I have some firm views, I think we have to be careful because the model we have for ACC at the moment is that private insurance model, which is they have to be able to fund today all their the lifetime liabilities that they carry on their books at the moment, hence their massive balance sheet. It's on the principle that if ACC was abolished tomorrow, all those who are in the system and are expecting ACC to continue funding their treatment, their lifelong treatment and earnings-related compensation where that applies, they would continue to get that. There is a political debate about whether that's the right model for ACC, but I'll leave you to contribute to that in the appropriate time. What ACC should do with its funding is, again, that is an important debate for ACC and policymakers to have. I think there's a lot more ACC could be investing in that would be more preventative than just responding to those who are harmed and injured by accidents. The reality is, I think, for this government, the next big challenge will be looking at ACC's remit and how much longer do we continue to say, somebody suffering a stroke or a cardiac event is not, should not be covered by ACC. Do we actually go back to the original 1967 Woodhouse report and what was contemplated there about life events that take you by surprise and that sort of being covered or not? So, and I would welcome the contribution by health professionals into that aspect of the debate.
Thanks again, Minister. We appreciate that the time you've given us today out of your very busy schedule, which I imagine is incredibly busy at the moment, getting into things.
I'm going to Canterbury today,
Yeah.
so
Yeah. Excellent. Good luck.
looking forward to a warm welcome. Yeah.
Thanks very much.
Cheers.